Good morning, ladies and gentlemen. It's my pleasure always to be here in MOCAT, my beloved conference here, especially with the conjoined with the Ibn Haytham conference. And also I would like to give a special thanks for the organization committee and the scientific committee to be with them. I will talk today about something is we need it in our daily practice life. Maybe you know that I'm not very good in explanation with theory part, but I usually giving some tricks that we are seeing in our daily life practice. So, of course, I have no any financial interest with any material mentioned here. We have to know that the prevalence of diabetic retinopathy in Iraq or diabetes mellitus, usually we have a lot of cases, and we have to keep in mind the general rule is usually a poor control. So we have to understand and keep these 2 points with us. We know that the basic pathogenesis mechanism in diabetic retinopathy is usually started from the retinal ischemia that will lead to the VEGF expression, and VEGF lead to edema, and VEGF after that causing neovascularizations and the breakdown of the old blood and outer ocular barriers, leading to all the problems that we can see. But what are the relation with cataract surgery? So we have to know that what are the general principle in management of cataract with diabetic retinopathy. Rule number 1, do not remove the cataract unless it is visually significant or it's precluding the assessment of the fundus. This is very important. لا تشيل الكاتاراكت لأنه عنده كاتاراكت أو just إنه visual significance أو يمنع لك assessment of the fundus. Rule number 2, if cataract surgery is necessary, المريض هذا عنده cataract to affect the vision and is necessary, the fundus is visible or no. If the fundus is visible, please go for check 2 things. The patients have macular edema and assess it, and the patients have a PDR or no. So I have to check for 2 things, the macular edema and the presence of the PDR. Rule number 3, if cataract is completely obscuring the fundus, يعني أنا عندي cataract, white cataract, mature cataract, I cannot assess the fundus. What I have to do, either I will consider a concomitant anti-VEGF at the same time of cataract surgery, or I have to put a plan for the surgery. So let's take this scenario one by one and we assess them. Now in this case I have a cataract with a normal fundus or minimal diabetic retinopathy as it's appearing in this appearance in this patients is have a very mild diabetic retinopathy. So here, this patient is after the surgery. So what's the problem having the patient? Keep in mind, either it's a progression of the macular edema that you have, or the patients may develop Irving-Gass syndrome. So we have to keep in our mind that the presence of Irving-Gass syndrome is usually most common after these cases, and how to differentiate, it's very easy from the pattern of the OCT, as the edema is that's growing from the Irving-Gass usually started from the level up to down. Okay, so we have to keep in mind the presence of Irving-Gass syndrome after these cases. So what I have to do in this case is either consider anti-VEGF at time of cataract surgery, يعني anti-VEGF phaco injection إذا كان عندي poor HPI control, if I have more advanced retinopathy in the fellow eye, or I have a history of Irving-Gass in the previous eye. Even if no anti-VEGF at time of surgery, ممكن نستخدم the topical non-steroidal. Usually I prescribe it for the patients for the first week before the surgery and continue for 4 weeks after surgery. And of course, close follow-up for the patients by OCT early as possible. Scenario number 2, I have patients with a cataract and macular edema. What I have to? I have 3 options here. Either the patients have a mild extrafoveal edema, as it's appearing here, or the patients have diffuse edema, okay, or I have that edema involving the center, okay, but it is less than 350. What I have to do, if I have a mild extrafoveal edema, here no need to defer the cataract surgery, okay, بس ممكن إنه أنت at the same time go for phaco injections. However, in these cases, it's better to defer the cataract surgery and first of all fix the edema, because the patient will not improving from the cataract surgery. In cases of a diffuse edema, the central subfoveal thickness is more than 103.50 microns. This is a significant risk of worsening despite intraoperative anti-VEGF. So in these cases, go for anti-VEGF without cataract, and after that you can do combination anti-VEGF and cataract surgery. In cases of pre-existing edema, as I say in all graded, يعني في كل الحالات انت لازم تكمل بالنون ستيرويدال okay for at least 6 weeks. You have to go for OCT every 4 weeks and try to avoid the triamcinolone because it is toxic to retina and causing glaucoma. Scenario number 3, I have a cataract with a PDR. طبعا شلون نعرف عندنا PDR? It's very easy by seeing the peritoneal hemorrhage, the visible NVD or MVE, and the fibrovascular membrane. All these clues give you an idea that these patients have a PDR. So in these cases, as much as possible, go for PRB as much as possible prior to cataract surgery. If cataract prevent adequate PRP, in these cases ممكن أنطي anti-VEGF راح يسوي لي covering the first 2-3 weeks after the surgery, and I go for PRP after 4 weeks. التيبس اند تريكس فور ذا بي ار بي. عادة لما نشوف كاتاراكت نقول احنا ما راح نشوف الريتنا it's very difficult to do the PRP. No, it's opposite. Try. You can still doing PRP even in if you have the cataract grade 2 or grade 3. Go for maximal dilatations, use smaller spot size, and usually do frequent tilting of the contact lens. For post operative PRB يمتى نسوي البوست اوبراتيف؟ ورا اسبوع ورا اسبوعين. ان هنا عندنا controversy بهاي الاشياء, but better within 3 to 4 weeks, لا earlier ولا later. ليش مو earlier؟ لانه انا عندي استفاد من الكفرج اوف ذا انتي فيجف, راح يكون مغطي لي الاريا during the 2 weeks after surgery, وبنفس الوقت I have a clear lens capsule, يعني still this time I ما عندي لا فايموسيس ولا البي سي او. later is better is ليش؟ لأنه أول شيء عندي الكورنيال edema after the surgery will be improving totally, and I have a very good wound stability. In all cases, avoid excessive pressure on the cornea because you still have an opening of the wound of view. Cataracts with no fundus view, as in these cases, always check for the fellow eye. Always the patient ask the patient to bring all assessment, do P scans. For me, in all cases with a mild mature cataracts, I go for phaco injections. For all cases, after doing the B scan, I just ensure the retina is in place. I go for phaco injection at the same time. Cataract in patients who's scheduled for PVB. Here I want just to mention something. In cases of partial vitrectomy, try to avoid phaco. يعني لا نسوي فضل الجماعة الشبكية ونقول لهم انه احنا راح نشيل الكاتاراكت وخلاص هذا المريض يعني do this patients for you. No, don't do this favor. Let the VR surgeon do it by his hand. Okay? ليش؟ لأنه أنت if you're doing the phaco, the problem of vitrectomy to the patient to the VR surgeon is very difficult. You make it a very difficult strategy. So do not remove the cataract as a service to the retina surgeon. If you can see the fundus with indirect ophthalmoscope, then PPV is possible. Cataract surgery should ideally be done at the time of silicone oil removal. حتى يعني as a VR surgeons, they usually do not prefer to remove the cataract at the same session. They usually to keep the cataract to the next sessions of silicone oil removal. Do and don'ts in cataract surgery: make the best effort to implant in the bag. Try to avoid any residual cortex على مود الانفلاميشن بعدين. Try to avoid the capsular phimosis. شوية كبر الركسز مالتك. Usually إذا صار عندك any problems and you want to يعني implant in the sulcus, never use single beads. Never use single beads. Even if you have double haptics IOL, go for 3 beads of course. And remember that diabetic patient usually have a poor dilatation, so you have to محضر كل الweapons اللي عندك. Convert to ECC at any time and go for large rexes. Direct chopping is better, and emulsify at the iris plan, and should go for IOL and bag. Finally, my take-home message: cases with a minimal or no DR are very prone to post-cataract macular edema. Despite the good control, advanced retinopathy needs to be addressed prior to cataract surgery. If cataract prevent evaluation or treatment retinopathy, use anti-VEGF. Anti-VEGF is a very good weapon to control you at least for the first 2 to 3 weeks after the surgery. Thank you very much for your attention.